Good morning, or indeed at whatever time zone you're listening into. My name is Stefan Schraag. I'm a cardiac anesthetist and I work in the north of the United Kingdom in Scotland, and I'm happy to address the Harvard update this year. I'm talking about advances and controversies in cardiac anesthesia. But first of all, I want to give you my disclosures. These are the companies I've worked with over the last couple of years on creating advances in cardiac anesthesia. Now, let's get started with a view backwards over the last 25 years, the previous decades we were living in. I'm aware I'm speaking to younger anesthetists, to slightly older anesthetists like myself, who have witnessed a rather drastic change in our professional life. If we look back and look at what has been changing and what has been developed, we've seen quite a lot of refinement in how surgeons approach coronary revascularization, the refinement of their processes, of their tools. We've also seen a nearly complete shift from surgical to transvessel aortic valve replacements, or indeed other valve replacements. We've seen the progression of robotic and technically assisted surgery, about minimal invasive approaches. And we've seen technological advances, even in our practice, given the fact that we have ever more refined echocardiography machines that provide 3D, sometimes 4D animated videos and quantification of disease. Almost on a monthly basis, we're witnessing more interventional techniques, new devices coming in that we have to adopt in our practice, in our support of the procedure and of the patient. That means we have grown very flexible in what we're doing, but also from from a scientific point of view, we have also learned that we moved away a little bit from the first principles, from the basic research, and now more interested in outcomes research, in more global questions to ask, and some of it which I will discuss here in this lecture. But looking at the current issues that we have in a cardiac surgical patient, there is on top the change of the patient's phenotype. The term frailty has been advocated to describe the phenotype of the vulnerable patient, of the more usually elderly patient, but not entirely that, and a patient who is more vulnerable for the procedure and the aftercare. Part of that is increasingly recognize the disruption of cognitive function and delirium. Other major domains of interest, of research, and of concern is how we maintain organ integrity, how we protect our organs that frequently fail following cardiac surgery. And that is the overall outcome that we look at, how we contribute to a sustained recovery, a recovery beyond metrics that just describe in-hospital mortality or hospital length of stay. And only recently we have seen surgical and anesthetic literature geared to describe outcome interventions that address the day alive after surgery after 30 days. For example, to address the longer term implications of what we do. Now, generally speaking, cardiac anesthetists want to establish stable hemodynamics. That's the principle that we learn in our training and in everyday practice. We want to establish a balanced metabolism. We want to control hemostasis, or be on top of how to control it and treat it. We want to maintain the organ perfusion. and protect by doing so the cardiac, the cerebral, and the renal function. We was also to control the inflammatory process and the response that surgery and cardiopulmonary bypass bring to the patient. And doing all that and putting it together, we want to facilitate a mostly undisturbed and an early recovery. Now let's start with looking at organ protection. And some elements of organ protection are more important than others, but overall we're looking at many. Let's start with the heart itself. Ever since in the 1960s and 70s, basic research on isolated heart and Langenbeck's preparations showed physiological changes to perfusion according to ischemic challenges. The quest was on to look at pharmacological or other means to protect the heart from myocardial injury. And in particular in cardiac surgery, where the hypothesis was that the heart is supposed to be exposed to a ischemia reperfusion issue. And this injury has been looked at how various drugs can protect that, in particular volatile anesthetics. And this is a rather early 2006 review article by Jim Simmons and Paul Miles. And they looked at 27 trials for CABG surgery. And they looked at whether volatile anesthetics are indeed coronary protectives. And I must say, in clinical practice, in these kind of studies that they have looked at, they didn't really find much of a difference in myocardial events, ICU length of stay, or indeed mortality. Now, years moved on, new studies were done, larger studies, more refined protocols have emerged to look at this concept that volatile agents, which, as I said, in the early 60s with the isoflurane, looking at improving coronary blood flow and stabilizing endothelial NO related contractions. Now, this is a study which is published in the British Journal of Anesthesia in 2013, which is a meta-analysis, which is very fashionable at the moment and systemic, but it adds a Bayesian network meta-analysis to it, which is accounting a little bit for the power of each individual study, contributing to the randomized trials collection. It's run by a group in Italy, which is very, famous for looking after various studies in cardiac surgery, Landoni. And what they did is creating this network. And what they found out is that the volatile-based anesthesia seems to be reducing mortality after cardiac surgery when compared to intravenous anesthesia. Now, the editor points that it seems to reduce. It didn't say it does reduce. And it's quite important to look at this nuance in phrasing, simply because if you look at this forest plot of all the studies that contributed to the meta-analysis, you might find that the majority of these studies are consisting of something allowed between 50 and 100 patients, except one. And this is the one I highlighted in gray, which is the 2004 study by De Heert. There were 280 patients with volatiles and 150 patients with intravenous anesthesia. So, and this was the only study here in this kind of whole picture that pushed the whole thing to the left, which you can see by the overall odds ratio of 0.51. Now, let's have a look at this particular study and remember that the whole meta-analysis was looking at survival after cardiac surgery. Now, this is the paper I was talking about, and it is titled Comparisons of Volatile and Non-Volatile Agents for Cardioprotection during On-Pump coronary surgery. And in the method section, the hypothesis of that study was that volatile anesthetics is associated with less myocardial damage as evidenced by a lower troponin level. So this is a fair enough suggestion, and this is how the study was powered. Now, what they found is that the troponin T levels were indeed relatively scattered together, whether they had intravenous anesthesia or sevoflurane or desflurane. And also the mortality of the patients in total after hospital discharge and after 3 months are pretty much the same. The only difference they saw was after 12 months, the intravenous group had a 12% mortality rate, whereas the sevoflurane rate had only a mortality rate of 4%. So they concluded a mortality benefit for using volatile anesthesia. Now let's remember the study was powered for troponin levels, not for mortality. Now, if we would take out the HERT study out of this meta-analysis from Londoni, which is on the bottom half, then the odds ratio will be slightly different and indeed would not favor either treatment. So it looks more or less there is still equipoise in the question of volatile protection. And this would again be shown in an actual prospective randomized trial that Landoni and his group did thereafter. This is the results of their study published in the New England Journal in 2019. And they compared about quite a lot of patients in each group prospectively in this trial. And you can see the Kaplan-Meier curve of diseased patients following surgery are precisely the same for both groups, not just earlier, but also after a year. Other studies have actually found the opposite, that this is a study from Asia, from a group in South Korea. They looked at a cohort study of nearly 6,000 patients, where the 3-year all-cause mortality in patients undergoing CABG was slightly superior with intravenous anesthesia as opposed to volatile. Now, if the studies are so marginally different, and if the studies are not really reproducible, maybe there is no difference. And maybe it's worthwhile going back to first principles and looking at what is actually the hypothesis of how cardioprotection works. This is a study which just came out last month and was published in Anesthesiology, which looked at the simple question of whether hyperoxia or a surplus of oxygen in the inspired fraction, as opposed to a normal inspired fraction of oxygen, 80% versus 30%, and in a factorial randomized design, the addition or the lack of antioxidants like vitamins is actually changing the myocardial injury. And in this study, about 600 patients, that was quite standardized and prospectively documented, myocardial injury again was measured with a high sensitivity troponin through the first couple of days following surgery. And what they found is no difference in the troponin levels, either with a high or low FiO2 or with the addition or the lack of any antioxidants. So both increased FiO2 and antioxidants did not change the risk of myocardial infarction. Now, fair enough, these were not cardiac surgical patients, but this was a study that clearly looked at a physiological phenomenon that is, or should be, involved in the concept, in the construct of cardiac protection. And an accompanying editorial of Peter Nagele rightly suggests that if inspiratory oxygen concentration does not influence the risk of myocardial injury, means the oxygen content of the patient is independent of the myocardial injury, it may be reasonable to conclude that the etiology, the actual pathophysiology of perioperative myocardial injury is not ischemic, but based on other mechanisms. So keep that in mind when we look at a reflection on studies at the end of my talk. Now, another organ protection that is very much in the minds of cardiac anesthetists and cardiac intensivists is acute kidney injury or kidney injury in general. We see a lot of patients who have pre-existing kidney disease. But the process of cardiac surgery, the Csi is now considered an entity in itself and its own right. And it's the second most common cause of AKI in the intensive care unit. The pathophysiology of CSI is very complex, and probably we don't 100% understand all the processes, but it did include renal ischemia, reperfusion injuries, inflammatory challenges, oxidative stress, and other nephrotoxic processes. Although we base our assessments and our stratifications on the KDIGO guidelines, and we often use them as a benchmark and a comparator, the definition of the CSA AKI is still not quite clear, and it is not clear how to deal with it in clinical practice. Because we don't have a pharmacological or a non-pharmacological preventive strategy that clearly works in all circumstances. And studies have failed to show a consistent benefit of the suggested treatments. The management still remains multifactorial, and renal replacement therapy is still the ultimate treatment of patients failing their kidneys following cardiac surgery. Both of it has a huge implication on post-operative survival, on post-operative quality of life, and of resource intensity. And therefore, people have looked at biomarkers of things that we can do to identify AKI early or consistently precise to deal with the matter or even prevent it. And from the general array of biomarkers for inflammation, like interleukins, TNF-alpha, and CRP, we know that hemoglobin is important. But then we also need to look at cardiac biomarkers. We know that cardiac output, cardiac indices determinants of renal perfusion, and therefore proBNP, for example, angiotensin II are important factors that supplement our normal biomarkers of using glomerular filtration rate, albumin levels, and other urine analyses. But recently, the so-called cell cycle arrest enzymes or molecules like NGAL or TIM2 have gained interest because they are now available in ready-to-use, quickly available assays, and these have been now subject of scientific interest. And this is a study from Engelmann a few years ago, where they used a sort of management plan and a stratification plan derived from biomarkers as an intervention. They used the urinary biomarker, they draw in the morning after cardiac surgery, just a few hours later, maybe 12 hours later, and looked at whether they are very low, so they fast-tracked the patient straight away. They were low to positive, so they had a bit suspicion, but not very much, and they subjected these patients to a review of their nephrotoxic medications, continued their urinary output monitor. And those who had really high responses in the biomarker assay, they got, subjected to the acute kidney response team, which had a very close look at the patients, had a goal-directed fluid therapy, hemodynamic optimization, and transfusion thresholds. And doing that as a sort of clinical intervention, the stratification was able to reduce severe stage 2 and 3 AKIs by nearly 90%. So the monitoring, when it's related to an intervention, has actually shown a clinical improvement. Now let's move on from the kidneys to the brain. Cognitive dysfunction or generalized brain dysfunction and delirium post-surgery is a big and a topical issue. And it's specifically typical for cardiac surgery, where we for a long time know that this is a comorbidity, a complication that is annoying in the best of cases, but quite often with frail and vulnerable patients, a real issue for the patients and their relatives. It also is a burden to the healthcare system. Now, we know that a lot of physiological discussions were around what is the cause, what are the contributing factors, drugs, opioids, and all that. And I'll just leave that for others in the in other sessions to discuss. But this is a study referring specifically to cardiac surgery, and also has been published only 2 years ago, because it looks like what happens in cardiac surgery, as we know, is we on cardiopulmonary bypass, we tend to accept a level of hyperoxia. The bypass circuits are usually filled with 100% oxygen, and that leads to PO2 levels that are supranormal and are obviously prone to create hyperoxic challenges to critically perfused organs like the brain or the kidneys, and are such considered to be a potential contributing factor for the dysfunction that we see. Now, this is a study looked at 400 cardiac patients and looked at plasma concentrations of markers of oxidative damage, which is isoprostanes and isofurans, and hypothesized that hyperoxic cerebral perfusion damages are contributing to this cognitive dysfunction. And there was an association of these and the severity of, or the relevance of delirium in these patients. And it also was showing that plasma markers of disrupted blood-brain integrity was high in those who developed it. So oxidative challenge is a contributing factor. And these are the graphs showing on the left-hand side the progressive concentrations of isoprostanes and isofurans, the markers of hyperoxic damage, and the probability of delirium going up with increasing such agents. And on the right-hand side, the slight association, at least in higher concentrations, to the S100 binding proteins, which indicate disruption of the blood-brain barrier. So there is another angle of the physiological understanding of cognitive dysfunction and delirium post-cardiac surgery. And possibly a discussion should arise whether the management of the patient's oxygen levels, I mentioned that before, in association with the myocardial injury, is to be discussed and maybe rejudged. Now, another part of the brain topic is brain monitoring. Should we engage in brain monitoring in all patients, yes or no? And what sort of brain monitoring is important and what parameters we are looking at? Now, this is a study which is a couple of years old now, and it did not include cardiac surgical patients, but it's just an example of how if a study goes a bit too overboard in inclusion criteria or exclusion criteria, but is published in the JAMA, is highly recognized as a gold standard. Now, this study, the Engages trial, is a good study, but its implication, I would imagine, and I would suggest, is limited, especially when it comes to vulnerable cardiac surgical patients, because they, in the study design, discouraged to use anything but volatile agents and excluded, for example, ketamine, propofol, and all that. So it is very much narrowed down to major abdominal surgery, where a BIS-guided anesthetic did not result in a lower incidence of postoperative delirium. Now, other studies have shown that titrating certain elements of the EEG, in particular the burst suppression part, and notifying or adjusting the anesthetic input to avoid unnecessary burst suppression in the EEG is indeed beneficial. So brain monitoring, yes or no? I would say yes. Another component of brain monitoring is not just the EEG itself, which is nothing less but the cortical activation level, or the cortical level of suppression of anesthesia and surgery, is the oximetry. Cerebral oximetry in adult cardiac surgery is used for many, many years. But as you probably know, no definitive study has shown any interventions or any particular threshold for all. But in monitoring it in the individual patient has shown individual benefits. Now, this is a study that's done in the United Kingdom and only recently being published in the Intensive Care Society's journal. And they looked at an adjustment of the oximetry and an intervention in the oximetry based on the patient's baseline values. Everybody who uses cerebral oximetry knows that we often see patients who have extremely low baseline values. If you put the monitors on, the patient is still awake, breathing normal oxygen, is talking to you, it's no problem, have oximetry levels of 45 or 50. Now, these patients are the ones you need to be looking at, because they are the more vulnerable patients for an overall worse outcome. And we know that this is has the baseline value has a high predictive value when it comes to predicting delirium or any form of cognitive dysfunction. Now, and they saw indeed that maintaining cerebral saturations above the baseline would reduce time spent in intensive care and improve long-term functional recovery. But it didn't impact on differences like stroke or major organ dysfunction or individual physiological complications. So there is still some time to invest in studying brain monitoring in cardiac surgery, or even integrate EEG and oximetry in a more meaningful algorithmic way. Now, let's move on to the discussion on outcome and survival. I already mentioned sometimes survival and outcome is not the same and should be seen in a more differentiated way in the context of what we're doing. Now, this is an interesting study here, because it just shows how a large collaboration of academic institutions, and it's a Sino-American partnership here. He looked at a 5-year survival in patients after cardiac surgery and whether dexmedetomidine infusions does make a difference. You might remember dexmedetomidine when it was introduced. It was introduced in the operating room. It was introduced in the intensive care unit for sedation. It was introduced for sedation for children. It has a lot of clinical beneficial characteristics. It also has very many drawbacks. Dexmedetomidine is a hemodynamic challenging drug. It can be difficult to use especially when it comes to the proper dosing that you want to use. And modern pharmacokinetic, pharmacodynamic analyses and studies have shown there seems to be an offset level of blood concentration where dexmedetomidine is safe, and whereas it is slightly more challenging, a concentration of roughly about 0.5 mics per ml. But dexmedetomidine is a slow drug. It takes time to kick in. It takes time. The context-sensitive half-time is very low when you phase it out. Nevertheless, it is a beneficial drug when it comes to its pharmacodynamics. And this has been looked at in this study, perioperative dexmedetomidine and 5-year survival. And the interesting one was that if you look again at the Kaplan-Meier curve, the survival rate after cardiac surgery in this context is that the dexmedetomidine group starts with a slightly head start. The non-dexmedetomidine group in the first half year already has a dip in survival rate, and the two are then moving on in a rather comparable way, whereas at the end, 3, 4, 5 years, the placebo group drops further down out of this line. So there is a survival rate, and that seems to be a beneficial way of this drug. So dexmedetomidine is a contributing factor of improved survival, even though we don't really know the precise mechanism. We do know that cerebral protection is certainly a factor. Whether the impact on the autonomic nervous system, the heart rate variability, etc., is also beneficial long term is still to be determined. Now, I started the talk to look at the challenging that we face today. We have frailty. Frailty is a relatively modern term to describe in one word the phenotype of a vulnerable patient. And cardiac surgery is a huge challenge. The frailty and a huge challenge don't really go well together. So in this meta-analysis of over 65,000 patients, Jessica Lee, she looked at frailty or pre-frailty, mild variants of frailty, and cardiac surgery, and the outcome. And those with frailty and pre-frailty, it's associated with 2 or 1.5-fold greater adjusted operative mortality. It also is a 5-fold increased likelihood of not going home or a delayed discharge. And that's quite significant for managing patients. A nice review of Anthony Graham and Charles Brown about frailty, aging, cardiovascular surgery is a good review to suggest you to read. It again strengthens the strong association of frailty and poor outcome. But again, mentions that studies so far, and that was in 2017, there was not much of handling that certain interventions would actually change that risk. Meanwhile, the screening and the identification based on these phenotypic approaches has been started in many cardiac centers, including ourselves. And programs have arisen, including rehabilitation packages that includes nutritional support, anemia management, physiotherapy, and activity and lifestyle advice. And in extremely frail patients, we have adopted multidisciplinary team meetings together with cardiac surgical patients and the family to discuss the likely outcome in terms of functional recovery after cardiac surgery. So occasionally, we then question the sort of value of the cardiac intervention in the context of extreme frailty. And postoperatively, it's important that frail patients require the principles of geriatric care. In our own research group, we adopted a data science program that looked at risk assessment models based on machine learning algorithms. And we're looking at whether a frailty, delirium, or acute kidney injury, for example, can be predicted better than the traditional risk scores like Euroscore or Parsimon score. And we found that with the basic assessments and some basic blood tests, there is, quite a good performance of most of these models, especially the random forest and the BART-M model, that are performing much better than usually used, associations and traditional cardiac risk models. And if we know that these models do better, we may adopt certain risk stratifications and assess to reduce individual patients' risks. And the models perform usually better the longer the observation time is, but even close to time zero, just on the right-hand side, the performance of a positive prediction is nearly 90% on the area under the curve, with a negative predictive value of 75%, which is a reasonably good starting point with limited data and a time-sensitive model. The last thing I want to cover is a topic that cardiac surgery has adopted many, many years ago and is now extremely sophisticated in, which is esophageal echocardiography. Probably being in Boston, you're surrounded by experts who can tell you everything about how to do it well, how to do imaging, how to improve your exams, how to look at a structural exam and all that. It has been a mammoth effort over the last 10, 15 years to train people up on echo to get such a consistent outcome. But the question, apart from morphology and all that, is it any good in terms of outcome? Does it actually make a difference doing it? And the answer is yes. We didn't have these answers for a while because we were focusing on guidelines, we were focusing on accuracy of measurements, on improved performance, but is it actually making a difference? And you can see over a retrospective analysis from Medicus showed that increasingly people are using echo for CABGs, for example, and they're shown a lower operative mortality and increasingly engage in surgeon to change the operative plan. And also for aorta surgery, for valve surgery, this study has shown that in a large database of a large center, engaging with TEE in a systematic way has the ability to reduce mortality, stroke, redo operations, and particularly because you can engage in preempt complications that would otherwise become undetected, like early tamponade, leaking valves, or incomplete cardioplegia or grafting into areas with the angiogram didn't suggest, but the echo suggests wall motion abnormalities. And again, more and more surgeons want to see an echo, but what is still plenty, not all of the surgeons want to see an echo, which is hopefully changing in our institution and probably many in North America. It has become a standard for all open heart surgery, and we're training to become as standard monitor as many others. The essence is, and I come to my finish here, there is a weak clinical evidence on volatile cardioprotection, and if at all, its implications are rather unclear. Renal biomarkers may allow for early detection of CSA, AKI, but all the interventions that we suggest are still unproven in studies. Neuromonitoring and dexmedetomidine improve cognitive outcome in vulnerable patients, And frailty assessment works well if it's embedded in a tight program. We know that routine TE is beneficial for a variety of procedures, but the relevance of interventions on long-term outcome remains elusive. Ladies and gentlemen, thank you for your attention.